Hi everyone, welcome to the CBP nonprofit video presentation of our research publications. I'm Dr. Deed Harrison. I'm president of Chiropractic Biophysics Technique and Seminars, and I'm president of Chiropractic Biophysics Nonprofit, or CBP Nonprofit. If you've been following these videos, we try to do one a week on average. Sometimes we skip a week just due to time, but we're going through individually each one of our research publications for Chiropractic Biophysics Nonprofit and Technique. We've done approximately 150 to 160 peer-reviewed research publications, so everything going correctly, this should be approximately a 3 to 4 year project of ours, assuming that we continue our publications, which we will. This week we have a great presentation for you. It's really a case report. I've decided to throw a few case reports in the mix before we go through some of our older papers, which really lay out the background and reliability and the validity of our research track record and our publications. Sometimes you can get lost in that science, and it's nice to break it up with a few case studies. So to that end, we're going to do a cervical spine case report. Now this one, it's not formally published as of yet, but what it was presented at a peer-reviewed research conference in 2005. So it did make a scientific publication from an abstract point of view, and I think it's fair for me to go through it because this was presented in 2005. So this is our case report on cervical spine fusion with anterior head translation. It was presented at the World Federation of Chiropractic Research Conference in Sydney, Australia in 2005. I was the lead author. In fact, I was the treating clinician. My intern at the time, who's now a licensed chiropractor, Dr. Jacob Fisk, and then my late father, Dr. Donald Harrison, were all collaborating authors on this project. So to begin with, interestingly enough, this is slightly changed with today's knowledge. The surgeons are actually focusing on anterior head translation and its negative consequences post-surgically. However, at the time of this presentation in 2005, there was very little information written on post-surgical consequences of somebody that had anterior head translation following cervical spine fusion and surgery. So, introduction. Anterior translation, that's forward posture, has been shown to correlate to poor outcomes after lumbar spine fusion. However, it has not really been demonstrated in the cervical spine. Now realize this was 2005 and previously. So in the lumbar spine, we found Kawakami et al. Spine, volume 27, page 59 to 64. Kumar et al., European Spine Journal, 2001, volume 10, page 314 through 319. These two groups of researchers established that anterior thoracic translation negatively affects lumbar surgery. However, this had not been reported in the cervical spine. So the purpose of this present case was to present the resolution of impairments in a patient suffering from post-surgical axial, meaning spinal, of origin, classically in the cervical spine from the zygapophyseal joints or the facet capsular ligaments, with also true radicular type symptoms with numbness and tingling and weakness in the right hand. We treated them with CBP rehabilitative methods or mirror image methods, and our hypothesis is that anterior head translation was the cause, or at least partly the cause, of the patient's persistent post-surgical problems. Now, this gentleman was an occupation mechanic and also a truck driver. He was having some pretty serious problems gripping the tools and using his dominant arm, the right hand, and in fact, he was dropping some of the tools. So this was really impairing his ability to work. Okay, so he's a 62-year-old male, 5'8", 185. This is pretty reasonably fit for this age. He presented with chronic neck pain, chronic numbness and tingling into the C5, C6 dermatome. He also had right hand weakness and classically grip strength weakness. He also has low back pain. The past history is C5, C6 instability with cervical spondylosis. In 1991, he had a surgical intervention. In 1992, the instrumented hardware that they placed failed, and he actually had to have a second cervical spine surgery, and they put in anterior plates this time in addition to autologous iliac crest bone graft. And for those of you out there that may not know, that's where they take a piece of the hip bone. Autologous means out of your own hip, and they'll use that in the cervical spine on the anterior lateral aspects of the vertebral body to fuse that joint together. However, because it failed previously, they also put plates in, and you'll see that. So since 1992, after the second surgery, the patient's really suffered with post-surgical axial symptoms, and he reported the radicular symptoms are actually worsening. Okay? And by radicular symptoms, it's not classic radiating arm pain, it's more numbness and weakness, so clarification. So here's his lateral full spine posture. The posture is actually pretty good from the pelvis to the feet and from the thorax to the pelvis. The biggest problem is that he's got a major anterior head translation. You can see rounding of the upper thoracic spine due to that forward head posture and a little protraction of the shoulder girdle region. So the significant finding is a very large anterior head translation. Okay. NRS, numerical rating score, this person is a 6 out of 10. Now, this is in the moderate range. It's 1 point away from severe. So he's got pretty decent neck pain, and by decent, I mean it's really affecting him, right? Neck disability index is 18%. Now, that's not too high, that's mild. However, his main problems were with the grip, and we don't have a grip strength disability index in this particular case. So the neck disability, although it only shows 18%, you got to realize that he's more impaired than this with his extremity. Cervical spine range of motion, we did a three-dimensional validated range of motion for rotations. This system will look at velocity and acceleration of the movement, as well as end range of motion and coupled motion. Here we're just reporting the end range of motion. And what you see is the extension, 32 degrees, that's reduced. The flexion, 48 degrees, that's reduced. The left head rotation, 23 degrees, that's dramatically reduced. We should be able to go 60 to 80 degrees in this population. Right head rotation, 69, 70 degrees, that's actually within normal limits for his age. Lateral flexion to the right, 27 degrees, that's reduced. Lateral flexion to the left, 31 degrees, that's reduced. Now the main postures from the sagittal plane are forward head translation, also with some slight or significant head flexion. Now here's his lateral cervical, and there's 3 of them here. However, I want you to focus in on, let me get my cursor to pull up there, on the x-ray on the left. This is his pre-lateral cervical x-ray. You can see the total cervical curve is 27 degrees. Our ideal model in CBP technique that we've already went through, Spine 1996, shows that an ideal value should be closer to the 40 to 42 degree range. So he's 27 degrees. His anterior head translation, 59 millimeters. Now the average asymptomatic person has about 15 millimeters of anterior head translation. And the atlas plane line is kyphotic or tipped into flexion by 3 degrees. You'll notice here's the plated fusion, and he's fused straight. So what we have to do is we actually have to subtract one of the relative rotation angles out of his total curve because of the fusion being straight. Now in our ideal model, the relative rotation angle averages below C3 to C7, 8.2 degrees. So what we would do is subtract 8 degrees out of our cervical curve, and what we get is 42 minus 8 is 34 degrees. So the most curve that I want to see from C2 to C7 in this case is 34 degrees. Okay? If I use the average value of 6 degrees per segment, then I'm going to drop that down into the lower 30s. So he's mildly hypolordotic with a very, very large anterior head translation, 60 millimeters. What you have to realize is the end range of motion for forward head posture is roughly 3 inches, 75 millimeters. There's at least 3 reports in the literature that have established that. So this gentleman is near the end range of his motion for this posture. He's stuck with 59 millimeters of anterior head translation. That's a major problem, right? So what are we doing here in these other 2 x-rays? These are not post-treatment x-rays or correction x-rays. What these are is we're stressing his spine back towards neutral on the same day we took this initial x-ray, so we can do 2 things. Number 1, I want to see how flexible his spine is. Number two, I want to make sure that the cervical surgery is stable because he's already had a history of failure of the surgery. And then number three, I want to make sure that his spine is stable. Above and below the fusion, I want to make sure that I'm not seeing increased motion past the allowable range. Specifically, I don't want to see more than 12 degrees of segmental extension above and below the fusion. Okay, we run a risk of segmental hypermobility or instability at the joints immediately above and immediately below the surgery. So I look at these joints, this one here, this is 2, 3, 4. So I look at the 4, 5 relative rotation angle, and then I look at the 6, 7 relative rotation angle, and I make sure that they're staying under the 12-degree value when I stress him back into his mirror image posture. You could call this a correction potential film, which is trademarked by Dr. Scott in California, San Francisco, California, but we've been permitted to use that term, so a correction potential film, or you could call it a mirror image stress x-ray, which in fact that's what I'm doing. I'm stressing his spine into the mirror image, translation with extension in various amounts, and I'm seeing does that show any instability. In his case, it doesn't. What does that mean? It means that I'm safe then to pursue mirror image methods. I'm not worried about the instability, okay? But I do have to be cautious because of the multiple surgeries that he's had and the previous failure. Okay, so what it says up here, caution, be careful to check for hyperextension above and below the fusion. And then it reminds you what I just said. Normal for the curve, or ideal, is 42. Subtract the relative rotation angle because he's fused straight at the C5, C6 level. That leaves 34 degrees as his new ideal. Okay, so he is actually below ideal, so we'll call it mild hypolordosis. And then it says here no segment should have more than 8.5 degrees of extension. That's assuming the idealized value, but the actual cutoff would be 12 degrees for instability. Okay, so what do we do? Well, we're chiropractors, so we're going to treat him with traditional chiropractic methods in a safe manner. We're obviously not going to apply loads to the cervical spine fusion or to the joints immediately above. Right? But what we can do is generalized mobilization and manipulation. We can use instrument and diversified. In the cervical spine at first we would use the instrument to make sure it's safe, and then in the thoracic spine we can use manual diversified methods. So that's what we did for 10 sessions. So 10 sessions, 3 to 4 times a week, so approximately 2.5 to 3 weeks. And you'll see we did this to the cervical spine and thoracic spine. We did some stretching, PNF stretching, contract, relax techniques to get the tissue to actually move further into its range of motion. Focused myofascial techniques for the cervical and thoracic spine, and then we did some ice to make sure that we weren't creating localized inflammation by performing new procedures that he hasn't done in a while. Now, it's not that these procedures are dangerous, it's that we're doing something new, and you know what, if his spine hasn't moved like this in a while, then we're going to have a little localized swelling. We control that with ice or with nutrition. It's called best practices. So then we did a re-examination, I'll show you that. And then after that re-examination, we started CBP technique. Now this is a very nice report because what we did is we separated out traditional chiropractic care for the first 10 visits, only did that, then we re-exam, and then we move into CBP corrective care methods. Now you'll notice we only did 11 CBP corrective care treatments. Classically, we would do more like 24 to 30 before we do another re-exam. However, in this case, we did an early re-examination for 2 reasons. Number one, I'm still cautious because of the surgery. I want to make sure that what I'm doing is absolutely of benefit to the patient. Okay, so I'm overly cautious in these cases. It doesn't mean you have to be, it just means I err on the side of caution. Okay, number two, he's now going to change jobs and he's going to do some long haul trucking, and which is actually better. He's not able to grip his tools, and he wants to, maybe change occupations or change the type of work that he's doing for the same company. So basically, I'm going to lose my ability to see him actively, 3 to 4 times a week. He's going to be out of town. So we have to do an early re-examination for these 2 reasons. Okay. What did we do for these corrective care sessions? Well, we did mirror image, CBP corrective drop table adjusting. We did CBP mirror image corrective care instrument adjusting, mirror image exercise for his posture, and mirror image traction. We'll show you those. Now, mirror image, you have to realize, is a registered trademark for chiropractic biophysics. It is part of our treatment protocol. Okay, so while it's not shown on here, that's a mild typo. We should have the registered marks on there. It is a registered trademark of CBP technique. So when you see that, it shows it's CBP technique. Here's what we did. Mirror image drop table adjusting. Now, obviously, I'm showing a more aggressive procedure that we didn't start the patient on. We start the patient flat with no block underneath him, and then slowly start to work the head backwards over consecutive visits. What I'm showing is the more advanced setup. This assumes that we've done a few other treatments with him, and he's comfortable with this. So I've got a block behind the upper thoracic spine. It translates it and flattens out the upper thoracic kyphosis. We should also externally rotate the glenohumeral joint and retract the shoulder. You can see that the model here is not doing that, but that's what we would ask him to do. We then translate the head backwards with extension, and I'm using the cervical drop piece. Now my contact is like this. I'm on the zygomatic bones of the cheek. It's a very safe area to put load into, and it's a mild to moderate load. It's not extreme load. Right? So we're just dropping the table with approximately 2 times the weight of the skull, roughly. Okay? We would do that 1 to 3 times. And then here's the instrument technique. You can see here, I'm translating the rib cage forward, translating the pelvis backwards. It's not that he needed that much translation of the pelvis, but we're showing a full spine setup here. And then the head is translating and extending backwards. Also, the shoulders are retracted here, but I should externally rotate the glenohumeral joint. So this model is not showing that. I can apply my force with the instrument in any region that has a high population of joint mechanoreceptors or a high population of muscle spindles. So here we're showing the hip acetabulum area. You could go up to the glenohumeral area, and probably the best bang for your buck, because of the population of muscle spindle cells, is in the upper cervical region. Okay, but shown here is a hip acetabular mechanical thrust. Now here's the mirror image exercise. We put a block behind the back. We retract the shoulders, we externally rotate the glenohumeral joint, and then we ask the patient to translate his head and extend his head as far as he comfortably can. He's going to hold that position for 5 to 10 seconds and then repeat. Now, at the time of the reevaluation, 11 sessions of doing these mirror image procedures, 21 total visits, because we did 10 traditional chiropractic, then we did 11 CBP treatments. Okay? We have 21 total sessions. At the end of this, the patient was only able to work up to 30 repetitions. Classically, we want more like 50 to 100 repetitions. Hey, but we're only 11 sessions into the corrective care. He's doing 30 repetitions. That's pretty good. Okay? Here's the traction that we had for him. Now, shown here is more of the advanced setup. We start people just laying flat with no weight. We just hang their head back for 1 to 3 minutes. And then the patient, after 1 to 3 minutes, what they do is they slide down and they rest their head on the back of this chair. Over consecutive visits, what we do is we work up to where the patient can do anywhere from 10 minutes minimum up to 20 minutes in office maximum. It's better to do closer to 15 to 20 minutes to get proper connective tissue stretch and change out of those tissues. It's called viscoelastic creep deformation. However, the 10-minute mark is classically the minimum that we start to see good change. Now, after 11 sessions of this, we were able to hang approximately 5 pounds from the chin and the forehead. What that does is that forces the head to move backwards a little further and stretches it. So weight is important, however you go at patient tolerance. Here's what he was able to do at the 11 visit mark of doing this. 5 pounds for 5 minutes. So you can see he's, challenged by this. Some people go really fast, some people go really slow. So we're only at 5 minutes. We need to be up to at least 10, and we have 5 pounds. So right away, I'm expecting to see some correction, but probably less than what I would typically see had I done like 24 to 36 visits of this and the person was able to get up to 10 to 20 minutes of the traction. But this is how we start and we work people through it. So a real life case. Outcomes. I'll show you the actual reevaluations coming up, but what I want you to do is see the report of this. What we noted was gradual reduction in symptoms and improved physical performance throughout the treatment. At both the re-exams, he continued to improve. Interestingly, number 2, the range of motion did not improve after 10 visits of traditional chiropractic care. However, after corrective care using 11 visits of mirror image adjusting, exercise, and traction, we noted a 12-degree increase in his extension range of motion. This is important. This shows that, hey, traditional chiropractic may not always improve the range of motion. Anterior head translation, if the magnitude of it actually linearly correlates to the amount of movement in the cervical spine. If you don't reduce the head posture, you will not improve the range of motion. Okay, there's at least 3 reports in the literature that have established that. I'm not going to go through those with you, but you can look those up on your own. Okay. Also, the NRS, numerical rating score, the neck disability, and the SF36 and radiographic outcomes all showed the corrective care of 11 visits had positive effects on pain and patient-relevant outcomes past the initial 10 visits of traditional chiropractic care. Always get words from the patient. At every re-examination, you need to ask the patient a couple things. In addition to your standard evaluation, you need to ask them what is not improving, right? What is not improving? What are you concerned about, or are you concerned about anything? That's important. You've got to, converse with the person. You've got to connect with them. This is a real person. You've got to make sure you treat that person as a real human being. You have to have a connection there, right? So find out what's missing, what needs to be done, or if there's any concerns that are developing, right? And then handle those appropriately and professionally and discuss with the patient. And maybe there's a referral that's needed for this person. The other thing is ask them what is truly better. Get the one thing that they're extremely positive and happy about, right? This is important for the patient's experience and also for the doctor to understand what type of impact that they're having on this person. So here's a quote from the patient. Quote, "I am sore in the morning when I get up out of bed. However, before, the pain used to get me up." What does that mean? It means he's now sleeping through the night. He gets up, he's still sore, but before he started care with us, the pain would get him up out of bed. He wasn't able to sleep. Sleep and psychosocial and emotional well-being are intimately connected. If somebody cannot sleep through the night because of pain or some type of disorder, dysfunction, their body is not going to function right. Mentally and physiologically, internally, they're going to have problems and breakdown. So this is a huge finding for somebody. If you're able to improve somebody's sleep time and quality of sleep, man, that's a big deal. Okay, so he was extremely excited about that, and so were we. So here's the numerical rating score outcomes. Now look, initially he was a 6 out of 10. Traditional chiropractic does help people feel better. So if you look at this, hey, this is a good change. It goes from 6 down to 2 after 10 visits. The NDI, 18 up to 22. Now, you might look at that and go, oh, that's worse. Well, actually, it's not worse. The Neck Disability Index has a repeated measure error of each session to session of about 4%. So this is within the standard error of measurement of the actual questionnaire. It's interesting that his disability is not better, but his pain is better. And sometimes that's what happens. He's feeling better, but his limitations are not improved. And then here's his cervical ranges of motion. You can see there's really no statistically significant differences until we get to the y-axis, not the y-axis rotation there. But here, there's a 4-degree change here, but then there's a reduction here of 10 degrees. There's a 4-degree reduction here and a 4-degree reduction here. When you look at this overall, you would say really not much of a difference, except in one of them, right head rotation is actually 10 degrees worse of interest. That's kind of shocking. However, you don't know until you measure it. So you go, whoa, this is unusual. spinal manipulation didn't change his range of motion. In fact, one of them is a little bit worse. So then the second reevaluation, after 11 visits of conservative CBP care, and realized we had to go pretty slow with him, he's now down to a 1 out of 10 compared to a 6 out of 10. Now that's not a huge change in pain from 2 to 1, but it is a mild improvement. Here's the big thing. Look at the disability, 22 down to 12%. That's a big change in disability. That's almost a 50% change in the neck disability index by doing 11 visits of CBP care, and it did not change after doing 10 visits of traditional chiropractic care. Look at the range of motion. 32 degrees jumps up to 44. We're still below what we were here, 23, 63, 34, this is improved lateral flexion, and then 28. So we have two numbers that are considerably improved after doing corrective care with him. 12 degrees improvement in extension, and then 7 degrees improvement in right lateral flexion. And those would be above the limits of measurement and repeated measurement. So we look at this, we go, wow, CBP corrective care had a positive effect on pain, certainly disability, and range of motion. This is a big deal. Here's his before and after lateral cervical. We went from 27 degrees to 31 degrees. That's a decent change. That's not what we were really after. We were after the head translation. 59 millimeters down to 40. Now that's a big change. We're about a third improved in this anterior head translation. He's now at 40 millimeters. 40 millimeters is now, in today's world, it's been established as a cut point for people that do better after cervical spine surgery and people that do worse after cervical spine surgery. That comes from a 2015 paper by Tang, T-A-N-G, out of the Journal of Neurosurgery Spine. If you want to look that up, it's 2015 Journal of Neurosurgery Spine, T-A-N-G. Look that up, you'll see the 40 millimeter cut point. So getting this person in 21 total sessions, 11 CBP sessions, down to 40 millimeters is a big deal. It's a third improvement. However, the alternate of that is, you know what, we're not done. Okay? In the ideal situation, we're going to look at a patient, we're going to go, hey, you know what? We're just getting started. You've had 21 total sessions. This is great, but you're not done, right? Don't stop now. Problem is, the patient is actually feeling better. He is improving with his grip strength, but he's now changing occupation. He now can't come in more than once a month or once every other month. Bummer, right? What do? Do you say, oh, we can't see you anymore, that won't work for us? Or do you work within the patient's ability? Here's the reality of being a doctor. You are there for the patient, not the other way around, okay? So you need to work within that patient's abilities and their time and their limits, and then come up with a proper treatment plan. So that's what we did. We said, you know what, let's do our home exercises, let's do these things as much as you can, and then get in here as much as you can. Now, unfortunately, most people are not very good at doing their home exercises, especially a 62-year-old male. Chances of you being able to get that person to do daily rehabilitation on their own, not gonna happen, right? So what we did is we ended up seeing him about once a month to once every other month, and then we followed him for 3 years. Here's the 3-year outcome. Okay, 3-year outcome, we've lost a little bit of the correction, so now from 40 it goes to 46, but overall it's showing a positive effect of what we did with him. We have an approximate ½ an inch improvement in the head translation, and the 3-year follow-up shows he's approximately the same as what he was when he stopped the active corrective care. Okay, I don't have those numbers in this, but I'm going to tell you that's what we identified. Okay, the 3-year follow-up shows approximately the same type of pain and disability and limits that he had when he stopped. Now, this is a real-world case. You're going to see things work like this. You're going to improve somebody, and then they may stop for whatever reason. It's your job to work with them and keep them under some type of care and then follow them. It's important to see, does this really have a long-term effect? You know what, the short-term effects, you can take a drug and you can get short-term pain relief. That's not what this is about. This is about effectively improving somebody's pain, disability, and health and seeing if you can keep it that way. So the 3-year follow-up, very, very important. Okay? And actually, well, I guess I did. I forgot this. I I forgot I had this slide in here. That's kind of funny. But anyway, real world right here. You're seeing Dr. Deed forget stuff. Don't tell anybody. This is the 3-year follow-up, an average of 1.3 visits per month. And you can see over the 3 years, the total number of care, including the corrective care and traditional chiropractic care, was 59. What you're seeing is he lost a little bit of his pain improvement. He's up to a 2, but look at the neck disability index. It's at an 8, and that's a nice change. And then the 3-year follow-up, you can see that I didn't put in the range of motion, so we really don't know what the range of motion is. But you can see the pain and disability at 3-year follow-up, doing an average of 1 treatment session every 1.3 months. You can see that he's still improved. He's better than what he was when he started care. He's better than what he was after the first 10 visits, and he's approximately the same as what he was at the end of the 11 visits of CBP care. Hopefully you enjoyed that case. The relevance of this, you know how many cervical spine surgeries are being done out there? It's a lot. And in some areas, it's probably more than it needs to be, right? If you look at demographics with surgery around the United States and around the world, the rate of cervical spine surgery per capita, it depends on where you live. What that means, it depends on the surgeon that you go to, and it depends on the patient population. Some people really want surgery more than other people. And then some surgeons, they might do more surgery in certain cases. And so the rate of surgery fluctuates per the region of the United States. And this is well known in the literature. I'm not saying anything that's not reported in the cervical spine surgical literature. You can look it up. The problem is, many of these cases after surgery are just like what we've seen here. They remove the offending bone spur or herniated disc that's causing major spinal cord and major nerve root compression. That's a great thing for the patient. You decompress the nerve root, it provides that person relief. The problem is, if you leave them with anterior head translation, you're leaving them screwed up, pun intended. You're permanently impairing this person's ability to have a health status and quality of life that is good for them. What happens is it's a downhill spiral. We've seen it over and over again. The surgeons are now starting to report this. They're showing that anybody that has more than 40 millimeters of anterior head translation after surgery, they're the ones that have long-term pain and disability. You cannot leave somebody stuck like this. The challenge is these people don't have the flexibility and mobility. You have to work with them. You have to develop flexibility. You have to rehabilitate their spine. They're not going to do it on their own. People will not do this on their own. They have to be guided and cared for. You have to communicate effectively. You know what? It's going to cause some soreness in these people. They have scar tissue. They have major damage, not just from the injury itself, but from the surgery itself. It causes inflammation and it causes scarring. So you got to work with these people. You know, 21 sessions, I would have rather seen this guy for 100 sessions of corrective care, and then I bet we would have seen almost full correction. But you know what? That wasn't the case. But at least what we did is we got him some correction and some significant relief to where he was much better than what he was when he started. This is what's needed out there. If you're a case with post-cervical spine surgery, you need to absolutely look up a CBP corrective care chiropractor. Go to www.cbppatient.com and find a chiropractor that's trained in these methods. They will help you. It may be a long, slow process, but it will eventually improve your pain and disability if you'll work through it. Okay? If you're a chiropractor out there, hopefully you're doing this type of work, and if you're not doing this work, then come to CBP seminars and learn how to do this. We train chiropractors how to properly do these procedures with people, how to walk patients through this so we get the best possible outcomes and we connect properly with that patient. Hopefully you'll also continue supporting CBP nonprofit. You can do that in one of two ways. You can go directly to our website at the link shown here, or you can support us indirectly through Amazon Smile. All you have to do is hit CBP Nonprofit or Chiropractic BioPhysics Nonprofit as your nonprofit society to support, and every purchase you make through Amazon Smile, they donate 0.5% back to CBP Nonprofit Research. Thank you very much for your time and attention, and I'll see you next week in our video research presentation. Thank you.